Welcome to episode 24 of the Mindstew podcast. My guests today are Bruce Wampold and Pim Cuijpers, two of the leading experts in the research of the effectiveness of psychotherapy. Bruce is Emeritus Professor of Counseling Psychology at the University of Wisconsin-Madison and author of the seminal book, The Great Psychotherapy Debate, The Evidence for What Makes Psychotherapy Work. Pim is Professor Emeritus of Clinical Psychology at the Department of Clinical, Neuro and Developmental Psychology, Vrije Universiteit Amsterdam, and is also Director of the World Health Organization's Collaborating Center for Research and Dissemination of Psychological Interventions. I first came across Bruce's book, The Great Psychotherapy Debate, not long after I started my undergraduate education in psychology. The main argument of that book was that the differences in effectiveness between different psychotherapeutic approaches were negligible, and that what really drove change in psychotherapy were the factors common to all legitimate psychotherapies. This struck me as a really counterintuitive argument at the time, and I didn't really know what to do with it. And so it kind of faded into the background of my mind as I progressed through the psychological education. But as I reached the end of my training, in which I switched more to a clinical focus, Bruce's argument kept popping into my mind. It was certainly at odds with the way I'd been trained, which was focused particularly on a single gold standard, evidence-based approach, namely cognitive behavioral therapy. And his argument was also at odds with what I saw as the guidelines from peak bodies for psychology and for psychologists, which were always structured with a particular intervention recommended for a given disorder. So it was a real pleasure to be able to speak to Bruce in this podcast and ask him how to square those two things. And because the argument was so counterintuitive and seemingly at odds with psychology education and guidelines, I wanted to bring another expert into this conversation. And I couldn't find anyone better than Pim Cuijpers, who has devoted his career to understanding the effectiveness of psychotherapy and also heads up a unit for the World Health Organization researching the effectiveness of psychotherapy and developing guidelines for the dissemination of psychological interventions. So I hope you enjoy this conversation with Bruce Wampold and Pim Cuijpers. We go deep into the effectiveness of psychotherapy, the comparative efficacy of different approaches to therapy, how to research what makes psychotherapy effective, and what we can do to improve the quality of psychotherapy and reduce the mental health burden. Without further ado, I give you Bruce Wampold and Pim Cuijpers. Bruce Wampold, Pim Cuijpers, welcome to the Mindstew podcast.
Thank you.
Thank you for the invitation. I'm looking forward to it.
Same here.
Likewise. I want to start off really broadly because your work, both of you, covers a whole lot of other research studies. We're really pulling together a broad field of research here, which is research into the effectiveness of psychotherapy. So really broadly to start, what can we say about psychotherapy and its effectiveness?
Well, I like to say that psychotherapy is remarkably effective. I think it's pretty amazing that a patient can sit with a therapist for the model of 50 minutes an hour, and that's an effective mental health treatment. Just 50 minutes of talking. Well, there's maybe a little more than talking, some exercises, homework perhaps, but it's essentially a social influence activity that is primarily a conversation. And it's as effective as medications for most non-psychotic disorders. That's pretty freaking remarkable to me.
Yeah, I agree with that, that it is remarkable. I do think that the effects are a little more modest. They're not that big. So we wrote a paper about that for 8 mental disorders. And there you can see that, yeah, between 30 and 42% of people respond, uh, differing for the different disorders. And response means that their symptoms go down with about 50%. And that's good, and it's better, actually better than drugs for depression, at least. At the short term, the effects are comparable, but at the longer term, so after 1 year, the effects of psychotherapy are better than those of drugs. So even one brief treatment of depression is better after 1 year than taking the whole year antidepressants.
Yeah.
And so psychotherapy is certainly impressive in terms of outcomes. But there is also room for improvement, because there are a lot of people who do not respond to the first treatment. And then you can go on with the next treatment and the next treatment, of course. And then it takes more time. And in the end, we can get everybody better. But it's not true that, if you take cognitive behavior therapy or behavioral activation, that everybody gets better if they've had it. Actually, it's the majority who do not get better.
Yeah. So, Pim, we're starting off with agreement. This is great. But I want to expand on that a little bit, on 2 points particularly. Yes, not everybody gets better. But if you go to nnt.com and look at the number needed to treat statistics for medical procedures, you'll find that commonly accepted, expensive, and actually quite dangerous medical procedures are much worse. So take coronary bypass surgery. The NNT, I looked this up the other day, I think is 12 or 15 for preventing another cardiac event. That's 1 out of 12, and that is much worse. We know cardiac bypass surgery is very dangerous. Many people die on the table, have a stroke, cognitive impairment. So, yeah, compared to medical treatments,
Yeah,
psychotherapy is pretty effective. The second point is, people will point to, relapse rates. Okay. Well, mental disorders, for the most part, are more like chronic diseases. Now, if you have diabetes, you don't go and get 6 or 12 weeks of treatment, and then we look to see if anybody relapses in the next few years. No, there is nothing really disturbing about the fact that many people with mental disorders will need to come back and get another course of psychotherapy 2-3 years. That's a remarkable and expected outcome. We get to crisis in our lives, and with those of vulnerability for a mental disorder, will suffer. Come back, get treatment. It's just as effective in the next course. We know, for depression, Pim, that often there's a stressful life event. There's a breakup of an intimate relationship. There's a death. There's a change in job status. There's economic challenges, maybe racial and cultural difficulties. Psychotherapy is there for additional courses, and relatively inexpensively.
Yeah, I fully agree, certainly with the last point. With the first point, I also agree. I mean, compared to medical procedures, there is no reason to assume that psychotherapy is less effective. You have to take into consideration that the NNTs in, for example, heart disease are not about depression, but about dying. So I'm not sure if you can compare that.
Yeah.
And in addition to that, I think therapies are good, but we should do better because not everybody gets better, and we should be able to get everybody better. And we have hardly any research on what do you do when people do not respond. And I think that's we need that kind of research. We certainly should do better than we do now. We are already doing great in psychotherapy, but there's still a lot of room for improvement.
Yeah.
And I think we shouldn't let that go because we think that everything is wonderful. That's
Yeah.
not the case.
I agree with that exactly. We do need to improve. And I think when we get into it, uh, uh, the course for improvement is where Pim and I may disagree.
Great. Well, that will be interesting, I'm sure, and definitely something that I wanted to get into. But just on this topic of effectiveness, so far we've been speaking about psychotherapy as a whole, as sort of like a singular thing. Of course, historically and in practice, there are all sorts of varieties of psychotherapy. Um, what can we say about the relative effectiveness of different psychotherapies?
I think
Well,
Bruce and I also agree on that one. That's especially in depression. Most research is on depression. So depression is the disorder where we know most about. And there the evidence is pretty clear that all well-developed psychotherapies have comparable effects. We did a very large network meta-analysis a couple of years ago with more than 300 studies showing that all major therapies have comparable effects. Only non-directive counseling was a little less effective than other therapies, but that can very well be an artifact because that is often used as some kind of control
yeah,
condition. And it's not serious therapists who are trained in delivering that therapy who give these therapies. And so I'm not convinced yet that non-directive therapy is less effective than other therapies.
yeah.
If you look at the studies where it is conducted seriously, then the effects are comparable to those of other therapies.
So there's 2 points I want to make
Yeah.
about this. Yes, depression is a great example because there's been more clinical trials of alternatives to the kind of canonical CBT. So the 2 points I want to make is first, psychotherapy is not like a drug where from trial to trial everyone gets 20 milligrams of the drug and we know exactly what the treatment is. Okay. Even if you titrate the drug, it's a pretty standard and you know exactly what the patient's receiving. Psychotherapy, even for the most rigorously manualized treatment, will differ dramatically depending on the patient's presentation, comorbidity, personality, and a lot of different factors. So psychotherapy is when we talk about it is different than when we think about prescribing and administering some kind of medical treatment like a drug. The second point I want to make is because Pim, you raised this idea of seriously administered. And I use the term legitimate. There's a reasonable, cogent rationale and therapeutic procedures given by a therapist who believes in the treatment. But in psychotherapy, we have this phenomenon where some things that might be called crazy or pseudoscience seem to work. So the case in point I want to raise is around present-centered therapy for post-traumatic stress disorder. This was originally developed as a control group, and it was for women who had suffered a sexual assault. And they were not allowed to talk about the assault because talking about the assault in the comfort of the therapy room with an empathic therapist is a form of imaginal exposure. So we want to design a treatment that doesn't have imaginal exposure or cognitive restructuring. So we have this present-centered therapy. When it was manualized and had some therapeutic ingredients, and the therapist believed that this would be effective, has in many trials now been comparable, and not worse than, but comparable to prolonged exposure. Now, we could say, oh, is the dodo bird won or the dodo bird lost? Is this an example of everything works? That's not what interests me. What interests me is how can we design a treatment without the two ingredients that we think are critical in treating PTSD, and it works. That tells us something about how psychotherapy works. And frankly, a result like that, and there's several of them, ought to keep people who are promoting a single treatment up at night thinking, how can something like that work? But for me, it's a chance to really understand what makes psychotherapy work.
Just before we go there, can I just check? So the focus was primarily on depression, this finding that different modalities are the same in terms of effectiveness. And you talked about PTSD there. Does this apply for all major conditions, or are there any exceptions to this where there is a significant difference between treatments?
Well,
Yeah,
here's the way.
there are quite a few meta-analyses of direct comparisons. So we summarized that in a paper a couple of years ago. And many indeed do not find differences between therapies, but not all of them. And so there are some direct comparisons between therapies where one therapy is superior to another. And you can say, okay, these trials were biased, or the quality of these trials were not optimal. And that's usually the case, but that's the case with most trials. Also, the ones that do result in comparable outcomes. So, my vote is that we're not certain that about whether all therapies are effective or not.
Yeah. Well, I would say this. For most disorders, the direct comparisons do not show meaningful differences, and ones that have been replicated. We did a paper, Pim, about the major results in the treatment of anxiety and depression, and the ones that show fairly large differences have never been replicated. So, the null hypothesis is there are no differences till somebody really definitively shows that there are. We've kind of lost Pim here a little bit. But there are a few conditions that we ought to talk about. So one is simple phobia. For a simple phobia with no complications, I would say, exposure therapy. There are protocols for simple phobias that I think are really convincing. The problem is even though the prevalence of simple phobias is relatively high, nobody sees them in practice, okay, for the most part. I just did a workshop in Lisbon, 28 therapists. I asked how many had seen in their practice a simple phobia, and nobody raised their hand because you avoid the situation. If you're afraid of spiders, you just call somebody to take care of the spider. So we don't see that. And often phobias occur within a whole array of comorbidity and difficulties. So that's one area. The other is obsessive compulsive disorder. So there haven't been good trials to compare response prevention and exposure to other treatments. But it looks like OCD might be a little different. OCD is not placebo responsive, which makes it different than most other mental disorders. But I will say this, if you read the trials on OCD, they measure almost solely symptoms, the Y box. They rarely have quality of life. And I've talked to OCD behavior therapists, and they will say, yes, we can get people to stop washing their hands with response prevention and exposure. So this repetitive, obsessive, it's a compulsive behavior. But quality of life doesn't improve. The relationships don't improve. They don't go back to work. They're lonely and isolated. So, yeah, maybe for the symptoms of OCD, there is a indicated treatment, but as a general rule, I think you can go through disorder by disorder and not see any meaningful and replicated differences. And that includes some, you might think, the ones I like to say, eating disorders. And we could discuss for a long time that evidence. Substance use disorders, I think, is pretty clear that every treatment seems to work. So on and on.
Yeah,
Yes.
so I switched my camera.
Okay.
I think there was something wrong with my camera. Sorry about that.
Yeah, no, you look great now.
Even
Okay.
better.
Even better.
Yeah. Okay. Good. Hopefully, no more tech issues.
Yeah.
It'd be such a shame for this to be, undermined by tech.
Yeah.
Okay.
Yeah. So, Bruce, you were saying that all therapies have comparable effects across all mental disorders. But I'm not.
I wouldn't say all mental disorders. We have to be careful. For some, there's not sufficient evidence to assert that positively. But I would say until someone presents evidence, we have to accept the null hypothesis that there are no differences. That is the default in science. We don't want to accept something is true until there's evidence to support it. So the null is there are no differences.
Have
But
you seen
again,
the overview of meta-analysis we made in the annual review of clinical psychology a couple of years ago? There we have collected all meta-analysis which directly compare therapies with each other. And we do find that many of them indeed show comparable effects.
well,
But it's not
Pim,
true for all disorders and all therapies.
okay.
So sometimes psychodynamic therapy is clearly less effective than other therapies.
Well, first of all, meta-analyses are not direct comparisons. You can meta-analyze direct comparisons, but you can't say a meta-analysis is direct comparisons. So psychodynamic therapy is less effective for which disorders?
For depression,
Okay.
there are indications that that may be the case, but I don't know them by heart. Let's see
Yeah.
if I can find them.
Yeah. Well, I would disagree with the depression one. But
But you can certainly analyze differential effects between therapies. So if you have
well,
direct comparisons between therapies, you
yeah,
can just do a meta-analysis. Otherwise, if you don't agree with that, then all the evidence showing that all therapies have comparable effects is away,
okay.
because
Well,
that's
I'm not going to make a blanket statement that all psychotherapies for every disorder are equally effective, and I've never said that. I would say there's insufficient evidence to show that one therapy is more effective than another in a reliable and validated way for most disorders. And I gave the exceptions where we don't have evidence yet. One is OCD, another is simple phobias. Um, uh, but the important issue for me is how this can be possible. I mean, we were taught that depression is caused by maladaptive thoughts and problems with core schema. And that's clearly not the case. We have to really rethink how we conceptualize how psychotherapy works. I think the evidence is despite what we might argue about for some particular disorders, really presents evidence that we have to think more deeply about how psychotherapy works than just take each therapy as a case in point of the um, mechanisms of change. So cognitive therapy doesn't work, and I think the evidence is pretty clear, or at least it doesn't uniquely work through changing of cognitions and core schema. There's, there have been dismantling studies, take those things out. Neil Jacobson did, the treatment still works. This tells us there's something kind of at a higher order level that really is critical for how psychotherapy works.
Yeah, I'm happy that you say that not all the evidence supports comparable effects of therapies across all disorders.
Yeah,
I do agree that's true for most comparative studies and for most meta-analysis in that field.
yeah. Isn't that
However,
quite isn't that quite amazing, Pim? I mean, you would never see this in
yeah,
medicine.
no, but I don't think you shouldn't compare psychotherapy with medicine. It's a completely different thing.
Yeah,
But
good.
I agree about CBT, and
Yeah,
I mean there is no evidence that CBT works through changing how you think.
yeah,
There is not enough evidence to say that.
yeah.
However, there is no evidence whatsoever for any therapy how it works, and that's the problem. And
I, I
the problem is that randomized trials are very well capable of showing if a therapy works, but not how it works. Because you randomize people, one group of people, you split them into one half gets the treatment, the other does not get the treatment. Logically, if you find differences between the treated and the non-treated group, that cannot be something else than the treatment. That must be caused by the treatment. If you but if you want to do research on how therapies change people, that's a completely different story. We cannot use randomized trials for that. Yeah, we can use dismantling studies in which you add one component or remove one component of a therapy, but these trials have not been done with enough power, so we just don't know which components work.
well,
And if you wanna examine how the mechanisms work, We simply don't know. There's a very nice paper from Alan Kest and Bruce, you definitely know it, from
Yeah.
2007 on mediators and change mechanisms, saying that we simply do not have enough research on any therapy on how it works. We just don't know how therapies work. And then, of
Well,
course, it's true that different therapies have comparable effects. And you can say, yeah, psychodynamic therapy is so completely different from CBT, and they have comparable effects. But it's still also true that depression is a very, very complex disorder. And maybe if you change how people think, that also changes how they solve problems, and
yeah,
that how they change their thinking may result in how they solve problems, what behavioral activities they do, etc. But you could also say, well, maybe if we teach people how to solve problems, that also changes how they think, what their behavior
yeah,
looks like. And so
yeah,
the mechanisms can be different while the outcome is the same.
yeah,
And we just don't know. There's no evidence whatsoever showing if a therapy works, if CBT works through changing mechanisms or through common factors like a therapeutic relationship between a therapist and a patient. We don't know. And
yeah.
that's well, I know, Bruce, you have a lot of these fights with CBT people and all the other people who say that should manualize, and that there's a lot of evidence on cognitions and all that. But I don't support these people either. I'm
Okay.
in between. I'm just an
Yeah.
agnostic researcher. I think
Well,
the CBT people go too far in their claims, saying that it works through changing
yeah.
cognitions. But I
So,
also you go too far in saying that it's caused by the common factors. My
well,
my my standpoint just is that we just don't know, and that
well.
we need more evidence to show how therapies work.
Yeah. Well, Pim, this is a great kind of elicits a point of difference. So, um, it's not just the common factors. The common factors are a little more complex than saying relationship, empathy, alliance. It's much more complicated. That's why I developed kind of a contextual model, because it's you need those specific ingredients, not because they're particularly aimed at the psychological deficit, the experimental psychopathology that underlies the particular disorder, but because it's a cogent rationale for the problem. It lays out a plan for remediating it. CBT, great. Changing cognitions and working on these schema, really great stuff. But so is experiencing and expressing emotion, let's say in emotion focused therapy or in some psychodynamic therapies. I would say, one of the things that makes psychotherapy work is that the therapist persuades the client to do something that's really beneficial in their life. And thinking about the world more adaptively is a great way to start. But so is experiencing and expressing emotion, for example. Okay, second point is we are making headway in understanding how psychotherapy works. The research using multi-level models or other techniques are looking at changes within the patient over the course of therapy is starting to reveal about what are the mechanisms of change. Okay, so for instance,
Yeah,
study.
yeah,
Yeah,
I know there's a lot of research on that, but the problem is that you can never be completely sure how therapies work. You
Well,
know if they work, but not how they work. And that needs large research programs. And I know there's a lot of research being done into that. But if you think about the complexity of showing how a therapy works, then you cannot say that we're there, that we're understanding it.
oh, we're definitely
Doesn't
not there.
mean that doesn't mean that I think if you have a good therapy, which is emotion focused, and it helps people, I mean, use it as much as possible because that's in the end what we want to do.
Yeah.
But it's not true that we understand how it works. I mean,
Well,
if you look at the alliance, for example, that's always um, you can only examine that within the therapy, and then you assume it's there, and you need just assuming an association with alliance and outcome. That's far too simplistic. And of
well,
course, you need
uh,
time, multiple measurements showing the improvement in alliance comes before the change in the outcome. But even that is not enough because there are always other possible factors that make things more complicated. I'm not saying it does not work that way,
yeah.
but I would be more reluctant as a scientist to say that we understand how it works.
Well, I agree with you. We can't say we absolutely understand how psychotherapy works, but science is incremental. We are making, I think, progress towards understanding how psychotherapy works. Now, yes, studying psychotherapy because it's a remarkably complex, context dependent activity is very difficult. But let's come back to the alliance because that is one of the so-called common factors. Uh, and it's hard to study. You can't randomly assign people to a high alliance and a low alliance condition. But we do this with in-person analyses. We disaggregate therapist contribution and patient contribution. No matter what we do, it seems like the alliance always there. So then, what do we do as scientists? Well, sometimes we have to look at related fields. And if you look at relationship factors in the effects of placebos, you can experimentally manipulate many relationship factors. And the results are absolutely stunning. How the relationship between the prescriber of the placebo, the feelings of warmth, caring, trustworthiness, and the competence of that person has a great effect, augments the expectancy effect of the placebo. That's experimental evidence. Now, it's not psychotherapy, but we really have to think about the related areas that show some convincing evidence for the power of a clinician to influence the health status of a patient.
Yeah, I of course I agree with that, and of course I also think that the relationship between a patient and a therapist. I mean, that's how we define therapy, right?
Yeah, yeah,
Therapy is a relationship between a patient and a therapist. And if the relationship isn't good, yeah, then the therapy isn't good. I mean, you don't need research to show that. But to really show that this relationship is the thing that changes, that's the mechanism of how people change. I think it's too early to say that. And I'm happy with any research from placebo, from any field, which brings more light to that and that we understand it better. And I'm very impressed by the research that is done on the alliance, and that gives more information to understand what that actually means. And in that sense, I fully agree with you. But as a scientist, I would be reluctant to say that we know how therapies work and that it's the common factors that make it work. I would say we don't know. And probably the relationship between the therapist and the patient must be there, because otherwise it's no therapy. But I think it's too early to say that we understand how therapies work and that common factors or a contextual model is already there. Apart from that, there's one other thing. So we had a discussion a couple of years ago, and I raised the same point there too, and I want to raise it here too. One important thing is that if therapies have comparable effects, so you have a lot of therapies and they all have comparable effects, and we agree on that. There's no significant difference between therapies. For me, clinically, the most important question is then not how does it work? The most important clinical question is, can we take off things from therapy without losing its effectiveness? Can we minimize therapies so that they're still effective but take less resources? Because, as you probably know, 80% of people with mental health problems live in low and middle income countries. That's about 800 million people across the world. There are more people with depression in China than the whole population of Spain. There are more depressed people, depressed adolescents in India than the whole population of the Netherlands. So if we want to do psychotherapy if we want to make psychotherapy available for 800 million people in low and middle income countries, and more than half of people with mental disorders in high income countries who do not get good treatments now, we cannot just provide psychotherapies in the current way, because you need to train so many people. There is no task force to do this. So if we want to provide effective treatments to all those people across the whole world who need it, then we need to simplify our treatments, see what we can do to keep therapies effective, but make them briefer, shorter, deliver them digitally, make them so simple that also non-clinicians can provide them. Develop the single session interventions that are now being studied a lot in the US. And so I think the question, how do therapies work? Interesting from a scientific point of view. And then my conclusion is, no, we're not there yet. We don't know how they work. But clinically, I would say that's also not so relevant. We need to adapt them so that we can help all those people across the world who do not get these fantastic treatments now. And therefore, we need to change therapies, simplify them, make
Yeah.
them different than what they are now. And that's,
Well,
yeah,
Pim, I agree with that. I mean, it's a very passionate and I think poignant point to make. I mean, we access to treatment not just in low income and middle income countries, but in a rich country like the U.S., access is still problematic. So you're absolutely right. But what we know about how psychotherapy works is really critical to the ideas you're talking about. You can't just simplify the treatment and say, here, hand the clinician, whoever it might be, trained psychotherapist or a peer counselor or a paraprofessional, whatever you want to call it, and say, here's the simplified version. You have to remember the context, the relationship. And I think the investigations like for Daisy Singla about behavioral activation in India, the relationship and the picking the people in the community who have the natural skills to be able to deliver effective treatments is absolutely critical. So if we don't take what we know about the interpersonal part of what we do, we're going to disseminate treatments that are not optimally effective. Now, you mentioned internet therapies, and that's a different topic. But let's not forget that we can't forget what we do know about psychotherapy as we go on this simplification process. And I'm not sure simplification is the best word to use, because it sounds a little condescending to say, your developing country or low income country will give you something simple. It's kind of taking the essence of the psychotherapy, and much of it is who's the therapist and how they deliver it. And I agree with you then that we should do this.
Yeah. I'm glad that we're in agreement here. I do think that we should be a little more open to other approaches than building everything based on traditional psychotherapy. I mean, we did a meta-analysis on in digital interventions. It's very clear. I've been involved in many randomized trials on digital interventions, and we use trained master psychology students to help people go through the online treatment. So
Yeah.
basically, you write down a treatment as in a self-help book, put it online, and then people guide the patient through the online self-help therapy,
Yeah.
basically.
Two
And
points about that.
I have a few points more to make about that. So if you look at these guided self-help digital interventions, they're not less effective than face-to-face therapies. The effects are comparable. And we always thought that you've also unguided digital interventions. So if you go on the internet and you read about what you can do about your mental health problems, but there is no therapist or coach or whatever to help you through it. And usually we find that these unguided interventions are less effective than the ones with guidance.
Yeah.
Which supports the role of a coach. It's not a therapist who does that, but it's human support. But now we did a meta-analysis in low and middle income countries where we found that unguided digital interventions have comparable effect as guided interventions in low and middle income countries. And that's not so strange, because usual care, which is often the control group, often means that people get nothing. While in high income countries, usual care is then people can get quite some treatment. And so, I do think we should learn from psychotherapy, but I also think we should try to be independent of it. If we want to develop interventions that are scalable, that we have to be original if we want to do something about all these mental health problems in 800 million people across the world.
Yeah, I'll say a couple things. One is, the idea that you need psychotherapy to change has been, I think, pretty much discredited for years. I mean, John Norcross has done brilliant work on bibliotherapy before there was an internet and bibliotherapy work. Some people can change from reading about it. Some people can change through religious or spiritual practices, but some need the interpersonal context of psychotherapy. So there's this isn't like, okay, we're going to substitute mental health apps. Pim, I think there's now 100,000 mental health apps on your phone. Most that are downloaded are never opened, and those that open them use them for one session. So this isn't the solution. Now I'm involved in development of some, so I think there is the possibility there. So that's one point. Second point is, as you say, relationship seems to matter, even in the digital therapies. So if you have a coach or a clinician who you can contact, even if it's asynchronous contact, is superior. And the alliance measured with that clinician or coach makes a difference. So we're in a brave new world in terms of technology, but I think some of the old principles are still there.
Yeah, I think in broad lines we are fully in agreement about this,
Yeah,
and
yeah,
it's I agree that there are lots of apps. Of course, there are thousands of apps available, but you also see that the number of trials on apps is increasing rapidly. We did a meta-analysis this year in World Psychiatry, and a couple of years ago we did that too, and then we had 60 trials, and in a couple of years that increased to I think 170 trials. So
yeah,
the research is exploding. Of course, cell phones are not the same as digital interventions. The digital interventions that most research is on are old-fashioned in the sense that they take a live therapy and put it on the internet. You write it
yeah,
down as in a
yeah,
book, and
yeah.
yeah. I also did research on bibliotherapy, by the way, a long time ago, and that's where my interest in digital interventions also came from. I like the idea that you can help people like this, and I fully agree with you that a lot of people will not be helped with digital tools or whatever, and they still need face-to-face therapy. Um, but then still, we need to see how we can do that most efficiently because there are so many people with mental health problems. We need to make that more, um, uh, more scalable. But anyway, I think we're in agreement about this. So whoever thought this, Bruce?
Yeah, I, I agree. Well, Josh, help us
Yeah.
here find some areas where maybe there's some differences in our opinion.
Yeah, well, I was thinking maybe it'd be good to have you both positively articulate a vision for the way forward. We're talking at sort of public health level, therapy effectiveness. They're both important, but maybe some important differences in your views will come out if you start getting into what is the way forward.
Yeah, if you talk, I want to narrow it down a little bit than just the way forward because, casting the future is always a difficult task. I phrase it as if we ask the question, how could you improve the quality of therapy? What would you do? And I think that's an interesting question. For me, it comes to the therapist. Over the years, I've looked at the outcomes of probably tens of thousands of therapists. Okay. And I've supervised probably thousands of therapists by this point. we're getting old, Pim, so the numbers are getting bigger. And the variability in the outcomes among those therapists is dramatic and both encouraging and disturbing. Okay, so early on, I looked at outcomes of thousands of therapists, and there were some therapists that absolutely helped almost every patient. Okay, if they helped kids, they helped adults. If they were good at severely distressed patients, they were also good at moderately distressed patients, and on and on. In that same database, there were some therapists that never helped a patient in 3 years. Okay, every single patient deteriorated. So, what's clear, regardless of the treatment, some therapists are consistently and reliably superior to others. There are some real experts, and there are some, and Michael Barkham, one of his papers, called him the worst therapist. I try to call him the poorer therapist. Regardless, so there's some absolutely brilliant CBT therapists and some relatively poor ones. Same psychodynamic, emotion-focused therapy, whatever you want to talk about. So for me, let's quit arguing about which treatment is best and help therapists individually improve their outcomes. And that's what I concentrate on. Now, to help therapists improve, we have to know what characterizes an effective therapist. And it seems to be clear that the most identifiable difference is the more effective therapists have a set of sophisticated interpersonal skills. Tim Anderson calls them the facilitative interpersonal skills that can be used, that are used, I should say, in challenging emotional material in the session. And supervising therapists, I see this. There are some therapists who are really effectively engaged when emotion is high, fear, sadness, withdrawal, and these facilitative interpersonal skills or sophisticated set of interpersonal skills can be taught and learned through deliberate practice. Therapists can practice these skills and get better. In our field, therapists talk about therapy. They're really good at talking about therapy, but they don't get better over the course of their career. We have research to show this. We need to actually break this down into the skills that are necessary to be effective and train it the way we train experts in music or chess or athletic performance through deliberate practice. If you read the expertise literature, structured practice with feedback and a coach, absolutely essential to getting better. Rarely do we do anything like this in psychotherapy training or practice. So, my mini lecture, Josh, both Pim and I are retired, so we don't have a captive audience anymore. So we love to kind of expound our ideas for an audience. But that's it for how I think therapists can improve.
Yeah, that's really interesting. I want to throw to Pim, but just on that firstly, so part of what I heard you sort of say before in terms of important common factors or how you define legitimate treatments is having a rationale that's understandable that the client or patient can buy into and get on board with. But then if you're saying that what really makes a difference and how to improve therapy is focusing on skills, how does that then get married to a rationale? Do therapists import that to whatever modalities they like, or is there some sort of meta
Well,
rationale?
yeah. So if you look at Tim Anderson's facilitative interpersonal skills, he has two of them are verbal fluency and persuasiveness. So, how you explain the treatment in a way that's verbally fluent, not just cogent, but interesting and convincing, the persuasive part of this, are therapist skills. So, I ask therapists to explain the treatment they're delivering to patient. It's one of the hardest skills to learn and master. And I've gone through videos from the American Psychological Association, and it's really difficult to find instances of those master therapists explaining what we're going to do in therapy in a verbally fluent and convincing way. So that's part of the skill.
Pim, do you want to respond to any of that?
No, yeah, maybe I should give my view on how we should improve and how
Sure.
what Bruce says fits into that.
Sure.
I do think it fits in very well. So I think psychotherapies are, you can look at it in two ways. So you can see if we can improve therapies, and that's the first thing I want to talk about. But you can also talk about implementation of therapies. How do we get the therapies to the people who need them? And these are two completely different things. And because of the time, I will only focus on the first part. And if you look at even broader, you can also try to see how we can reduce the disease burden of mental disorder at a population level. And then you can also talk about prevention of mental disorders, which again is a completely different field. So I will try to focus specifically on how we can improve the effects of therapies, not about implementation, not about preventing mental disorders altogether. And I will focus on depression because that's what I know most about. And most of my research is on that. So if you look at the outcomes of psychotherapies, they are good, as I said in the beginning, but we need to do better because there's a lot of people not responding. And when I look at all the promises over the past decades, I think uh, none of them has shown to be true. And we just published a paper in the Journal of Affective Disorder in which we looked at what happens in usual care over time in these randomized trials. So we looked in primary care, specialized mental health care, perinatal care. And what you see is a flat line. Therapies do not get better. And response rates are lower than what you find for the active treatments. So obviously, it seems that all these therapies that we examine and compare to usual care and always find that they are better than usual care, they're not used in usual care. They're not implemented in usual care. That's an important thing to remember. But if you think how we can do better, I think there are several ways. We shouldn't focus on new therapies. I mean, that's something that happens a lot in routine care in high income countries. There's a new therapy developed based on clinical new ways of looking at a mental health problem. And the promise is that it's much more effective than the therapies we had. People are trained, go to conferences, they buy books, the developers give lectures. And when you look at the outcomes, they're never better than the ones we had. So developing new therapies and wasting time and energy on getting trained in new therapies, that's just a waste of resources. That's not the way forward. The way forward is that we should think mostly about process things because that's where we see a few things where we can improve, um, and not about the content. So we did, for example, we found very clearly in a meta-analysis that if you increase the frequency of sessions, that you have better effects. So if you have 2 sessions per week instead of 1 session per week, the effects go up. We did a randomized trial to confirm that, and we did indeed confirm that. 2 sessions per week is better than 1 session per week. That will not get this. So we have a response rate of 42% of people who get treatment for depression responding. If you would say, okay, we're gonna increase the frequency, maybe we can get that up from 42 to 48%. I don't think it will be much more. The 6% increase is just a rough thing, but that's where you have to think of. I also, Bruce, Mike Constantino. He did a brilliant paper in JAMA Psychiatry a couple of years ago, where we matched the patient and the therapist based on the question of the patient and the qualities of the therapist. And he also found that if you do that, then the outcomes are better. And so maybe there is also something that we can increase the response rate from 48 to 55%. And maybe if we train therapists better, like Bruce proposes, maybe we can increase the response rate from 55 to 65%. But then I do want to see first a randomized trial in which you show that. Because if you have therapists and you cannot train them, they're untrainable, and you cannot fire them, then it's no use for getting the outcomes better, so to say. So my response to Bruce would be, that sounds wonderful, sounds very promising. Now show me a trial that if you train therapists, that you actually improve outcomes. And then I think there is a lot of other things we should examine, where we can take another chunk of those 60% of the people who do not respond to therapy now. So we have these stratification studies, large data sets with large groups of people who get therapy. And maybe we can match patients with therapists better. Maybe behavioral activation is easier to understand than cognitive therapy. And it's better for some people to start with behavioral activation. Or maybe it's better for them to choose the type of therapy they want to start with.
Yeah.
Or maybe we should have a sequence where we start with the cheapest intervention and then do a stepped care model. We don't know all these things. But I do think that if we start examining these steps that you can take, if you start with this therapy, that's better for this person than to start with that therapy. And there's a whole area of research that we haven't done yet. And so I think the promise of the future, how we can improve therapies, is we are already good, but we can improve by taking off chunks of the people who do not respond now. And that can be all kinds of different things. No new therapies, but things in the process, things in how we offer therapies, in what sequence, when do we start with drugs in depression, that kind of thing. If we do that, then I would say if we have enough resources to do that research, maybe we can double the response rates in 20 years' time. And that is only about improving therapies. I haven't talked about dissemination because that's a different thing, which is also important, because if you can do single session intervention, for some people, that will make mental health care a lot simpler and cheaper, making resources available for other people we can help.
Yeah. Well, Pim, that was a lot of great points to think about. And I'll just say simply, I think I agree with everything you said. But most profoundly, please, no new therapies, no resources devoted to the training. Nobody improved their outcomes by going to any of these trainings. There's research to show that. And I like the emphasis on preference. We know preference for the type of therapy produces better outcomes. Ideally, there would be a choice of therapists. Unfortunately, at least in the United States that I'm familiar with, just to find an available therapist is a challenge. To have a choice among therapists is a luxury that maybe only in New York City could you afford. Well, you couldn't afford the therapy, but you could afford finding enough therapists. We didn't really get into this, but you raised the point about mental health systems. And in the US, in many ways, our mental health system is dysfunctional. We could, I think the three of us, design something much better in the time remaining.
Well, we're coming up to time, not much time remaining, and it seems as though there was a lot of agreement and maybe less disagreement than I might have expected.
Well, Josh, I think it's a testament, and I'll say this to Pim and kind of immodestly to myself, that we're open minded in the sense that we want to find solutions to deliver the most effective care. And so this isn't about who's right or who's wrong, but about wrestling with these issues to come to solutions that use limited resources to provide the best care possible for the people who need it.
Yeah, absolutely.
Yeah, I fully agree with that. And I think clinical researchers usually come to an agreement when they talk with each other and they don't agree. Like with Bruce now, we do disagree, but not on the main things, namely that we have to improve treatments to help people. The big problems come when we have to talk with funders of research, because then we have to talk with people who think mental health problems are a brain disorder, and when you examine the brain, that we will find the solution. And if you look, for example, at the research on mental health in general, there's a report on this. Mental disorders cost about 14% of the disease burden of all disorders together.
Yeah,
But the money only goes to only 7% of the research in the biomedical field is going to mental health problems. And then
yeah,
by far the majority of that money goes to neuroscience, goes to examining the brain, genetics, whatever. But that has not helped any patient. So and I think that's where the real problem is. I mean, if we would have money for clinical research according to the disease burden at the population level, and we would devote 10% of the money spent on neuroscience psychiatry research, then we would improve mental health care within 10 years considerably. So actually, you shouldn't have invited Bruce and me because we disagree, but not on this thing. We
yeah,
agree that clinical research can actually help people, and that's not true for all research in mental health care. I'm not saying that this more basic research should not be done, because that's a long-term investment, because it can help to understand what mental health problems are, and maybe in the long term lead to new and better treatments. But we also have a lot of people at the short term suffering from mental health problems. And only a fraction of the money that should be spent on mental health problems, on clinical issues, that would make a difference for millions of people across the world.
Yeah, that seems like a great point to end on, to really just provide the important context for this conversation. So,
well, thank you, Josh,
thank
for
you both
inviting.
so much.
Yeah, thank you for inviting us, and thank you, Pim. Always a pleasure.
Yeah, thanks, Josh. This was you didn't have to say a lot, but it's still a good way of having this conversation. And Bruce,
Yeah.
it's always a pleasure to talk with you about these things.
Yes, great.